Recording in progress.
Good evening all. I welcome all of you for our next edition of 3 series in arthroscopy. And this week's program is going to be on cartilage injuries of the knee joint. And our top theme is on 2 talk on evidence and 1 talk on experience and expertise. That's the theme of our program. I would like to thank all our faculties who have joined to share their time and also to share their educational knowledge. And to talk about evidence, I have 2 speakers. And the first speaker is Dr. Rajesh Thunugunta from Hyderabad. He's going to tell us about cartilage injuries of the knee joint. What is the evidence for bone marrow aspiration concentrate, BMAC? And then next talk is going to be from Dr. Balasugumar. He's a consultant arthroscopy surgeon from Tirunelveli. And his talk is going to be on managing chondral defects with OATS and ACI, what the evidence says about. That's about evidence talk. And for experience and expertise, I have an experienced senior arthroscopy surgeon from Dubai, and he is Dr. Kundra, and he is my good old friend. And he is going to tell about his experience and technique about cartilage repair in the knee joint. He works for Med Clinic Parkview Hospital, Dubai, and he is clinical associate professor of orthopedics at MBRU, Dubai. So welcome all of you. Welcome Dr. Balasugumar, welcome Dr. Rajesh, and welcome Dr. Kundra. Welcome you all. And I thank OrthoTV for channelizing this program. Thank you Ashok, Shyam, and Neeraj and Poonam. And I thank Sun Pharma team for helping us to organize this program. And with this short note, I think we'll go ahead with the program. The talk will be like first 2 evidence talks will be for about 10 minutes each. And experience talks will be for about 15-20 minutes. In between, we'll have some time for discussion of whatever the doubts that we have. So let's go start with the first talk now. And the first talk is going to be on evidence of BMAC in cartilage injuries, and which is going to be told by Dr. Rajesh Thunugunta. Rajesh, are you ready to share your screen?
Yes, I'm ready, sir.
Please go ahead. Thank you for joining.
First of all, I thank Dr. Subramanian sir and faculty and organizers for giving the opportunity to present. Yeah, coming to the evidence of BMAC in cartilage injuries. Before going to the evidence case studies, just let us know what is bone marrow aspirate. As bone marrow aspirate is the one which has potential high quantities of hematopoietic fat cells and followed by lesser quantity of stroma of bone marrow cells constituting fibroblasts, macrophages, adipocytes, and osteoblasts and osteoclasts. And the last one to have as major constituent is a bone marrow having mesenchymal stem cells, which has major chondrogenic potential, and which is the point of interest for all of us today. So bone marrow aspirate concentrate is the one who increase the concentration of these mesenchymal stem cells per sample volume, which usually forms 0.001% of all bone marrow aspirate bone marrow. And these mesenchymal stem cells has a strong self-renewal abilities, which can differentiate into chondrocytes, osteocytes, and adipocytes. Along with the higher MSCs in BMAC, BMAC also has higher quantities of hematopoietic stem cells per sample volume, as well as platelet derived growth factors, just like we see in PRP. So there is a picture showing how does bone marrow. How we do bone marrow stimulation. So bone marrow stimulation can be done either with a microfracture or Kirchner wire and motorized bulb, which increases the bone marrow at the level of subchondral bone. Along with that, if we add bone marrow aspirate concentrate, which has higher mesenchymal stem cells, will increase the chondrogenic effect that will form chondral regeneration. There is a principle behind the bone marrow aspirate concentrate. So coming to the studies, These are first. These article published in the Cartilage. These article published in Cartilage Journal in 2014, comparing the matrix-induced autologous chondrocyte implantation against mesenchymal stem cell bone marrow aspirate concentrate in patellofemoral chondral lesion. This is a non-randomized control. It is a non-randomized prospective trial, which was done by Alberto Gobi, and comparing the matrix autologous chondrocyte implantation and the bone marrow aspirate concentrate mesenchymal stem cells with using the same scaffold. The study was done in between 2005 to 2010, which is a prospective study having 37 patients of patellofemoral chondral lesions. 19 of them are treated with matrix autologous chondrocyte implantation, and 18 were treated with bone marrow aspirate concentrate. All the patients were evaluated with the MRI and the clinical scores pre-operatively, as well as 6 months follow-up, 2-year follow-up, and as well as final follow-up, that is at 5 years. So the authors has got a chance to do a second look arthroscopy in 5 of autologous chondrocyte implantation patients and 6 of BMAC patients, and they got a chance to do biopsy from that regenerated chondral tissue in 4 of each group. So the results for both groups showed significant improvement in all clinical scores as well as MRI. MRI shows has a complete fill in 76% of matrix autologous chondrocyte implantation and 81% of BMAC groups, which are equally good. And the main feature is they could find a highly like morphologically, they could find the cartilage as highly like tissue in MRI. So these are pictures showing retropatellar chondral defect, and which was prepared, and this with the graft template of cultured chondrocyte and with the chondrocyte with cultured chondrocyte implantation done. And this is a picture showing BMAC. First picture showing a retropatellar chondral defect, and this is activated BMAC clot, and which was applied over the chondral defect and stabilized with the fibrin seal. In the second arthroscopy, the first picture showing matrix autologous chondrocyte implantation at 29 follow-up, and this picture showing the second picture showing 24 months follow-up of BMAC. Both are comparable, having a smooth surface, stable graft unfolding with good fill over the chondral defect, and the tissue is well integrated, which is inseparable from the subchondral bone. So, concomitant biopsy was done in 4 people of each group, and they found that the tissue is like a highly light and fibrocartilage-like tissue, which is a mixed picture that is better than what we get with only microfracture chondroplasty. And these MRI picture of MAC and BMAC showing a complete chondral fill in both the pictures at final follow-up without any bone edema. So the study concludes that both autologous chondrocyte implantation and MSc BMAC are viable and effective for the treatment of large patellofemoral chondral defects. As we know already, is autologous chondrocyte implantation is established treatment for chondral defects, but the main disadvantage is the patient has to undergo 2 surgeries, and it is not cost effective, and the patient has to undergo the morbidity of 2 surgeries. So with the main advantage of MSc is mesenchymal stem cell BMAC is a single-step surgery with chondrogen potential and no need of a second surgery by doing chondral biopsy and cell cultivation. But still, the study says it has its own limitations with being a non-randomized control study and less number of patient groups. And these other study, which was published in Orthopaedic Journal of Sports Medicine in 2000. By Leopard et al. Is a systemic review of outcomes which was done from 1918 to 2016 with inclusion criteria of BMAC treatment for the chondral defects and osteoarthritis and all other animal and basic science studies were excluded. And which has a total of 11 studies, including 5 prospective, 1 retrospective, and 2 case studies and case reports, and 3 comparative studies, and none of them are randomized. And 3 studies were on efficacy of BMAC and osteoarthritis. 8 studies were on the efficacy of BMAC and focal chondral defects. And all the 3 studies and all the 11 studies have shown good and excellent outcomes of BMAC in chondral defects. And this is a study, bone marrow aspect concentrated cartilage defects of the knee. This is a benchside study, and which was done. This is a literature review which was performed in February 2017 using PubMed and OATS Medline databases using the following keywords. And they conclude that the main component, active component of bone marrow is a mesenchymal stem cells having the power of chondrogenesis, and the associated cells has the paraclinic signaling activity which is mostly progenerative. And there is another study which was published in knee surgery in 2018, and this is a technique-based study which was developed by A. Shetty and Kim. Family is known as Kim Shetty technique. The main intention of this study is to develop a technique which is cost-effective and chondrogenic, and that should be a single stage. So the technique was developed. The technique was developed that allowed chondrogenic uncontrolled cells from BMAC with hydrophilic and fibular cataracts to apply to chondral lesion. This is a vertical translation methodology was done, means that the study was developed and first applied in animal studies, then taken to a prospective human studies. For this study, symptomatic ICR is grade 3 and 4A lesions were mapped and treated. And there is a demographic picture, demographic information showing age of the patient with mean age being 44, with mean size of the lesion showing 4 square centimeters, with chondral lesions showing 1 or 2 or 3, and the topography of the lesions in medial femoral, lateral femoral, and trochlea and lateral tibial plateau, patella and medial tibial plateau. So that this technique is famously known as MCIC technique, mesenchymal cell induced chondrogenesis technique, where basing on three factors, one being the concentrating the chondrogenic mesenchymal stem cells using fractionation centralization, and using this chondrogenic cells in a fibrin glue that allows to attach it to the subchondral base, and application of this chondrogenic fibrin glue at the subchondral surface arthroscopically by carbon dioxide insufflation. The main advantage of carbon dioxide insufflation is it even acts against the gravity, unlike dry arthroscopy. So this study claims improved results, improved clinical scores, which includes IKDSE, whose and all these clinical scores has improved preoperatively at 6 months, at 1 year and 2 years, and reached a plateau at 2, 3, 4 years. And this better clinical scores were maintained even after 5 years. Even up to 5 years. So along with the clinical scores, they also done a post-operative MRI, which showed morphologically good cartilage, which is equivalent to normal cartilage, and they claim it as highly like cartilage. So during the study, they're able to reduce the surgical time with no complications or lesser complications comparable to any other arthroscopic procedure. So they conclude that this technique is effective, affordable, and single-stage treatment, and accessible to any center where arthroscopy is done regularly. And they claim that this tissue is highly like cartilage based on MRI sequences comparing with the normal cartilage. And the procedure appears to be a shallow learning curve. And this is one more study which is published in the American Journal of Sports Medicine in 2019. Long-term clinical outcomes of one-stage cartilage repair in knee with the hyaluronic acid-based scaffold embedded with the MSC sourced from bone marrow aspirate concentrate. The study, these are case series done between 2017 to 2012 with minimum follow-up of 6 years, including only grade 4 chondral lesions of at least 1 centimeter square size and with age being limited to 30 to 60 years and with low BMI of 20 to 30 kg meter square. And the patient group should be at least play sports at least twice in a week. So MRI was done preoperatively and to examine the lesions and which were confirmed by diagnostic arthroscopy before going for cartilage lesion repair. Patients with multiple intraocular steroids, osteonecrosis, and tri-compartment knee arthritis were excluded, and associated procedures like ACL reconstructions, HTOs, TTOs, transfibular osteotomies, and lateral release was done as if required for the clinical clinical situation. And there is a picture showing bone marrow aspirate concentrate being drawn from the iliac crest and the retropatellar chondral defect being prepared, and with HA hyaluronic acid BMAC graft applied to the retropatellar graft. So this is the demographic picture showing with mean age showing 48 years, and the age distribution includes age less than 45 as well as greater than 45 with single as well multiple lesions with sizes less than 420 with the lesion size less than 4 square centimeters as well as 7 square centimeters, 4 square centimeters, and they claim that they claim the results show that there is improved clinical scores in 2 years as well as 5 years follow-up, and the results are the same in both the groups of less than 45 as well as greater than 45, meaning that there is no role of age, but they claim that younger individuals will have better results with BMAC than older individuals. So these pictures showing, irrespective of the number of compartments involved, the results are improved. The results has got improved, and irrespective of procedure done, the results are improved on all the groups. So the study conclude that the repair of the full thickness cartilage injury in the knee using HA-based scaffold provides good to excellent outcomes at long-term follow-ups in small to large lesions, and even in a single or multi-compartment lesion also, this BMAC has shown improved results. And as said already, in patients greater than 45 years, the results are good, but less than compared to age less than 45 years. Yeah, thank you. Hello.
Rajesh, thank you very much.
Sir, thank you, sir.
I think you summarized quite a lot of things.
Sir.
Any questions to ask? Can you stop sharing your screen so that we can have the discussion panel? I want to just clarify one thing.
Sir.
We told a lot of things about the good outcomes of BMAC. Sir. Are there any evidence about failures of BMAC?
Sir, as such, there is no evidence of failures of BMAC, sir. And the thing is, till date, there is limited articles and limited evidence for BMAC to support, sir. But the BMAC is going to be evolve as an alternative to autologous chondrocyte implantation. So it seems like that. But the main advantage is it's a single stage procedure, but evidence is still limited, sir. And as such, no failures has been seen. I mean, no evidence showing failures of BMAC.
As you can see in the chat box, there is a question about selection criteria for using BMAC in chondral lesions. Up to what size of chondral lesion we can use BMAC?
So in all the studies which we have seen, they claim that even 27 square centimeters lesions were also treated with BMAC. As such, there are no what I mean to say is, as such, there is no limitation for BMAC as of now, but it has shown equivalent good results in small as well as large lesions. The indications are yet to sir, yet to be formulated.
In my personal experiences, I used to do BMAC quite a good number of cases earlier. And still I'm using for some selective patients like where you find a focal defect of less than 2 square centimeters. Okay. As you are saying, 27 square millimeter you are telling.
20 square centimeters he has given in the article. Centimeters he has given like that, sir. The mean size is 6 square centimeters. The largest is the 27 square centimeter.
How about the patella? You found patella, they are not doing well, is it? For patella?
No, sir. In the articles, one of the articles has shown good results in patellofemoral arthritis as well, sir. The thing is, we have to correct the malalignment if any malalignment is there, sir. Along with the chondral repair, you have to correct the malalignment as well.
There is a series of questions from Thunugunta. Speed of centrifugation of each cycle.
So this speed depends upon the commercial companies. I'm not sure about the speed and the processor. So it's only commercial. Sorry, sir.
Thistle. Fibrin glue is called thistle. THISTLE. Okay. I think commercial brand names are quite a few companies are available. They can personally ask about it. Speed of centrifugation, to be honest, I don't know either how much they are putting. Because I think they might put 50,000 or something, but I'm not sure. How about you, Rajesh? You know about it? How much centrifugation speed they are putting?
I'm not sure. I'm not sure about that.
Not sure. Okay. Yeah.
Not sure.
Because it is predetermined for each group. So I'm not sure how much exactly they put a centrifugation cycle. The company leaflet will tell about it. We have a few more, like Dr. Balaraju is there, Rajol is there. Welcome. Hi.
Good evening, sir. Happy to see you after a long time, sir.
Hi. Yeah. So let's go on to the next talk then. If there is no more question, we'll go on to the next talk.
Somebody's asking for post-op protocol, sir. Post-op protocol, what they see intraoperatively is they want to make sure that this fibrin glue is firmly attached to the subchondral bone. They will do full range of motion intraoperatively and make sure that this fibrin glue is firmly attached to that base. And followed, so postoperatively also there is no limitation for ROM. ROM is done with a brace, and partial weight bearing is done after 4 weeks.
I think essentially for the first 4 to 6 weeks, you need to make sure that does not shear off whatever you have put. So you put non-weight bearing during that time. Okay, let's go on to the next talk then. And next talk is going to be given by Dr. Balasugumar from Tirunelveli, who is going to tell about evidence about ACI and OATS procedure. Balasugumar, are you ready for sharing your screen?
Yes,
please go ahead.
Yeah, I'll start.
Yes, go ahead. You can see.
Yeah. Thank you, sir. Thank you for this wonderful chance. Okay. Today I'll be talking about what the literature says about managing chondral defects with the OATS, the autologous chondrocyte implantation. Yeah. Okay. This modern technique of OATS was first described early in 1993, and there's a lot of study which is done by Hungary and Fuels. They have one of the largest number of study. All these are done to the mid of the 90s for the osteochondral defect. The mosaic-plasty was done during that time. Okay, this is one of the study where it has a long-term follow-up, about 10 to 14 years. What is the inference that the study has tells us the long-term clinical outcome after mosaic-plasty varies greatly depending on age, gender, and size of the lesion. Age meaning that the better results are given with the younger age group, that is less than 40 years, more than 40 years. The more than 40 years, the results are bad. Okay. I didn't tell what is OATS. OATS is an osteochondral autograft transfer system where from the non-weight bearing side where we are taking our natural cartilage and we are implanting on the place where it is defective, mostly on the weight bearing places. The advantage of this is getting the natural cartilage from there and getting it to a place where there's a defect. So the age is less than the 40 years. That's what the study says. The gender is male gender do better. The women gender tend to do poor. And size in the study, it's about 3 to 4 centimeters. Anything above 4 centimeters is not doing well with the mosaic-plasty. Anything lesser than that was doing good with mosaic-plasty. And the problem was filling the gap, because this will be taken in circles, as you all know, and filling the gap and leaving the defect there, and how to fill that defect has been the problem in doing the mosaic-plasty. This is another study where there's about 597 samples have been studied, and most of the samples from the female condyle, they did well. 92% of from the female condyle, they all did well. 79% in the long-term follow-up. This is like, say, 10 to 12 years, 10 to 15 years of follow-up. How in the clinical basis, and how the clinical study was done on different scoring systems for the knee. And the patient, when compared to microfracture, which they did good early in the stage of the procedure, but whereas the OATS, the people continue to do better and better as they progressed. So in this, the 92% of the people from the female condyle, they did well. From the 87% from the tibial condyle, they did well, and 94% of talar procedure also did well with this. Okay, whether this is done, what is the problem in doing this arthroscopically, or what is the problem in doing this as open? Open was usually the bigger lesions, it was easy to do by open procedures. The smaller lesions are single, where we need only a single graft, which was easier by an arthroscopic surgery. Which was more easy in the medial femoral condyle, in the lateral femoral condyle in arthroscopy because of easy the trajectory position. The commonest problem in the arthroscopy was doing this by the commonest problem in arthroscopy was hemarthrosis. Okay, when compared to microfracture, how did the patients do well in microfracture? As I did, microfracture, when it was a very smaller defect, when it is less than 2 centimeter defect, and it is not much in the, even if it is in the weight bearing area, if it is in the less than 2 centimeter defect, those patients did well for the microfracture patients. And all these microfracture patients did well in the earlier stage. In the long-term, longer duration study, all the patients, the OATS did very well than in the earlier stage of the procedure. In both the studies, it was concluded that the OATS patient did well in the longer stage. This is OATS procedure done in the children and the microfracture done in the children. In this, if you see, 91% of the people who did OATS did well than to the 56% of people who did underwent microfracture. This study is a long-term study, again, where this is compared with the autologous chondrocyte implantation. Here it says 10 of 58% of the ACA group, the number of the patient whose repair failed was in 10 of the 58% and 23 or 42% in mosaic-plasty. This is a long-term, this one of ACA. I'll be showing few more studies about ACA. OATS versus ACA, where the result demonstrated that there was no significant difference between the groups, but in the sub-analysis showed that in a Cincinnati score, there was a significantly better in medial femoral condyle defect, which was done by the autologous chondrocyte implantation. What is this autologous chondrocyte implantation? Where we take our own native. This has to be done as a two-stage procedure. First, we take the chondrocyte off. First, we take the chondrocyte off through arthroscopy, a few 150 to 200 milligram. Then it is cultured. Then the culture is kept in a scaffold and is kept in the defect. This was earlier first reported in 1994. The first gen, the scaffold is a periosteal scaffold, where the cambium layer is turned and it's kept there. The second membrane patch, the third is a matrix-induced autologous. The problem is the first gen periosteal patch was hypertrophy of the periosteum. And the problem with this procedure is a two-stage procedure. But the advantage of this procedure is that you can do this for bigger defects. Anything defect more than 3 to 4 centimeters. Okay. What is the limitation of this? The limitation of this is a higher failure rate, the survivalship, and the high cost of the surgery, and the whole maturation of the graft, the cells. We don't know how much cells have been live, how many cells have been matured so well. It all depends on where it's being cultivated. It all depends on specific different regions. So outcomes, how the outcome is decided, its outcome is decided by the size. We have very limited data for smaller size because for the smaller size, people don't go and do a two-stage procedure. Mostly a single-stage procedure is being chosen. The return to sports, there have been multiple studies showing that the higher return to sports have been seen in autologous chondrocyte implantation. Outcome by age, even in mosaicplasty and even in autologous chondrocyte implantation, people have done well. The younger people have done well. Age group between 25 to 40, they have done well. Even the age group less than 40 have done very well. Clinical failure rates, if you take both mosaicplasty and in autologous chondrocyte implantation, the longer studies, the 10 to 15 year study, there have been less failure rates in autologous chondrocyte implantation. And in image-based outcomes, there have been not much of difference between these both. When there's a repeat look that has been done by an arthroscopy and there have been biopsy have been taken, where they found the hyaline-like cartilage has grown in autologous chondrocyte implantation. This problem is not there in mosaicplasty because directly a hyaline cartilage is being kept there. So comparison of autologous chondrocyte implantation and microfracture, it has always been demonstrated that an intermediate and a long-term clinical research with autologous chondrocyte implantation has always been better. Whether there's a first gen or the second gen has been done well, there has been studies that shows where the first gen autologous chondrocyte implantation is doing good. This is a long-term follow-up of first generation, a 20 years follow-up of a first gen autologous chondrocyte implantation, where they had a satisfactory and a very good clinical improvement with that first generation procedure. Durability of the autologous chondrocyte implantation with the microfracture or the osteochondral autograft, that is a mosaicplasty. Microfracture tend to reach a plateau and it is deteriorating, and it might need a secondary procedure. And when it needs a secondary procedure, mostly people go with the autologous chondrocyte implantation. The results of autologous chondrocyte implantation tend to remain stable and they tend to improve on age. Improve with time. So, whether to choose OATS or an autologous chondrocyte implantation on a defect of 2 to 4 centimeters, what I read in these 3 days, that OATS is a single-time procedure, a single-stage procedure, which is easier in any part of the world, and which gives a natural, highly directly available for you without having depending on the lab, on the cultural facilities. The problem with the ACA is it is not easily applicable in all the places, and the need of a two-stage procedure, the need of a more costlier surgery. But the advantage has been more and more studies which have been published doing chondrocyte implantation, that is the ACA, come alone or with OATS, or in the athletic population, or in or in the knee population. That's all done well in the long-term study. All has been done well with an ACA. So that is my short presentation. I thank you, sir. Thank you, everyone.
Thank you, Dr. Balasugumar. Thank you very much. I think you well summarized it. If you stop sharing the screen.
Yeah.
So what is your take on for a defect of about 5 centimeter size? Would you go for ACA or what?
With what are the studies I saw, when the defect is more than 4, the ACA has given a good result.
Yes,
and the problem is not getting the graft to fill that 5 centimeter. And having the donor side problems if you have to take more graft. The larger the graft was taken, the donor side problems have been higher. But if it was taken for 2 to 3 centimeter, only 2 or 3 graft had to be taken. The lesser donor side problem has been there. And where it has to be filled, the defect has to be filled. Even there, if it was a bigger centimeter, this in between the circular graft, there has been defective, it is not been filled properly. So ACA is better in more than 5 centimeters.
Yes, very well, correctly said, because ACA gets its place mainly in the bigger defects. And number of votes blocks that we can use is becomes difficult when you have a bigger size. So around 3 centimeter, 2 to 3 centimeter, you are going for votes. Bigger size, then you go for ACA. But obviously, you very well told about one particular point about microfracture and ACA. Microfracture tend to do very well in the early stage. But later on, when you follow up them, they tend to go into a fibrocartilage. So they don't do very well. But ACA on a long term will do very well. Because its effect is remains same. Even though initial effect may be a little delayed, but the effect remains same even at a longer follow-up. That is a very good take-home point for ACA. Are there any other questions? Rick, are you? I can't see Rick Kundra in the gallery box.
Hi.
Rick, are you ready for your talk?
Sure.
Please. So next talk is going to be on the experience and expertise side, where Dr. Rick Kundra from Dubai is going to share his experience on cartilage repair in the knee joint. And he's going to tell about the techniques and his experience. Rick, please start sharing the screen. Thank you for joining us.
Can you see that?
Yes. Please go ahead.
Okay. Well, thank you very much, Dr. Subra, for inviting me. Pleasure to join you this evening from Dubai. So I'm going to talk to you about cartilage lesions of the knee, some aspects relevant to experience in this area. So these are these sort of areas I'm just going to touch on. It's a very short talk, so I'll keep it brief. Now, articular cartilage structure, we're all quite familiar with these histology slides. It has a combination of a extracellular matrix and then cells and the perichondrium in between. Right, so it's important to know that the cellular layer is arranged in a laminar fashion, with the importance here being of the calcified layer forming a very strong boundary between the chondrocytes and the subchondral bone, and this is important to be aware of during surgical techniques in this field. So as I said, chondrocytes are the smaller component of articular cartilage, comprising about 2%. The extracellular matrix is the majority component, and the predominant collagen in this is type 2, comprising about 15% of that matrix. So when we look at cartilage injuries, cartilage surgery, it's important to be aware of the concepts of the functional unit. So the functional unit can be looked at both macroscopic and microscopic levels, and this is important for us as surgeons to be aware of when deciding on treatments for our patients. At a macroscopic level, before we even talk about any cartilage procedure, we need to ensure that the patient has satisfactory alignment, the knee is stable, and any associated meniscal issues are dealt with before we even come on to cartilage problems. Because without these stable bases, the cartilage is not likely to do well. And on a microscopic level, when looking at treatments for cartilage problems, we need to ensure that any treatment that we provide has a suitable microenvironment with adequate growth factors, a suitable scaffold, and a source of cells for repair to obtain the best possible outcome. I think previous speakers have talked about this. It's very important to ensure in all of our searches for the optimum treatment that we're looking for hyaline or hyaline-like repair. There's a definite difference in the mechanical load to failure and stiffness compared with fibrocartilage of at least 50% when looking at fibrous versus hyaline cartilage. So this is the treatment algorithm that we tend to follow. Looking at cartilage defects. So for the smaller ones, we tend to go for OATS procedures because of problems I think the previous speaker mentioned with using larger or more greater number of plugs. So we're not big fans of doing mosaic plasties so much. I prefer to use a single OATS plug, so I will go even up to 11 or 12 millimeters, but a single plug if possible. And this is really to avoid problems with the lesion persisting between the plugs, problems with congruity, of having multiple plugs, mismatch in congruity. So they're sort of concerns that we have with using mosaic plasty. Purely chondral lesion, small lesion, less than 2 centimeters, I think the evidence does point towards microfracture, both on a cost effectiveness, ease of surgery, accessibility. So we tend to go more towards, I actually prefer a nanofracture technique rather than microfracture technique. So we're going for narrower, deeper holes to get into that subchondral bone marrow. The debate or the controversies tends to come with the larger lesions. I know in India you have good access to ACI, but certainly here in the UAE and also in the UK where I was previously, access to ACI is not so easy. So we tend to go more for either allograft, osteochondral allograft, or cellular options. And that's what I'm going to speak to you about later. These are for the larger defects. So microfracture we've done already. I won't spend too long on this. This is single stage, quite inexpensive, not technically demanding, but does need attention to detail to be done right. So very important to create vertical walls. Very important to address that tide mark layer that I mentioned earlier on the histology section. We need to break that down to allow cellular egress from the subchondral bone marrow. You need to ensure that the holes are adequate, deep enough, and we need to try to prevent heaping or bunching up of the bone at the site of fracture. And that's another reason why I tend to prefer nanofracture versus using standard microfracture awls, because you tend to get less heaping of the bone and less damage to the subchondral bone itself. There are problems with microfracture, intralesional osteophytes being one of them, that do tend to affect long-term outcomes. And of course, this creates a less durable repair using creating predominantly fibrocartilage with a much lower mechanical load to failure. Microfracture has been advanced or progressed predominantly by work carried out by Behrens and his team, where they came up with the augmented microfracture-induced chondrogenesis technique. This is using a scaffold as well as a nanofracture technique. In this particular case, Chondroguide was used. I tend to use Hyalofast more, predominantly because it's a HA-based scaffold, non-animal origin, which is important in this part of the world. And it breaks down reliably over 9 to 12 months, so leaving just the cells and the residual repair tissue behind. So this is my preferred technique for smaller lesions, using a nanofracture along with a scaffold such as Hyalofast, similar to the AMIC technique of Behrens. Good evidence to support its use. This is Elisabetta and Marcacci's team from Rizzoli Institute, Bologna, definitely supporting the use of this technique. Osteochondral grafting is what I would probably consider for a larger lesion. We tend to use we have used mega OATS in the past. Just on the right side here is the instrumentation that is available from some of the manufacturers to reliably create mega OATS grafts from allograft tissue. One issue with this, of course, is it is a very expensive procedure, but it is single stage. Use of the allograft option does avoid donor site morbidity. There are some synthetic options. Down here is the MyoRegen graft developed by the team at the Rizzoli Institute. This is a trilaminar graft, which tries to recreate the anatomy of the cartilage, or the osteochondral unit, with a layer replicating bone, cartilage, and then a form of the tide mark layer in the middle. This, however, requires quite extensive preparation with a depth of at least 1 centimeters deep to try and implant this graft. But it is an option to have to consider. But really, with these osteochondral options, apart from OATS, the expense is the main issue, as well as, of course, infection risk, and for the donor tissue graft availability is a concern. Reasonable evidence supporting use of osteochondral procedures for usually the larger lesions. I think the previous speaker has covered most of this, so I won't go into more detail here. ACI has also been covered, so again, I won't cover too much, apart from the fact that the expense of this process, lack of availability here in the Emirates and also in the UK, but not so much in India, I gather. There are some issues with ACI, of course, apart from just the cost issues. Graft hypertrophy has been an issue, and in my own practice in the UK, we did do a number of scopes where there was focal graft hypertrophy causing secondary symptoms in the patient, and this needed further surgeries to address by debridement. So then we come to sort of single stage cell based, which is what I'm tending to use now for the larger lesions. We currently have an international multicenter study underway, prospectively looking at our pooled outcomes from 5 international centers, the US, Germany, UK, UAE, and Switzerland, looking at this. This one on this image is actually not what we're using. This is commercially available particulate juvenile allograft, which is available off the shelf, but very, very expensive. This is secured in place, secured with glue or a membrane, and then left, essentially. But the results are very encouraging, but the expense is very, very high. Predominantly available in the US currently. So we use autologous cartilage chips. So there's been extensive work on this for over 40 years now. This started initially approaching 40 years now. This is Albrecht's work looking at a rabbit model, where cartilage chips were used in a rabbit model to produce hyaline-like repair. This was then replicated in a goat model, and then more recently in human studies. Most recent work has been by Gian Salzman in Zurich, and he's leading our study group at the moment that we're participating in, looking at this technique. This is Gian's results, 27 patients that he published in 2019. You can see the mean defect size quite large, 3.1, treating defects of all locations, including patella. And 93% satisfaction rates were obtained in this. So the technique itself is it's developed by Arthrex. It is the all-autologous chondrocyte regeneration, or AACR, or AutoCART, as we now call it. The aim of this technique is really to replicate the foundations of that functional unit that I was talking about at the beginning. So we're trying to replicate or provide the growth factors, regenerative cells, and the matrix to allow optimized healing of the defects. So in terms of the cells, these come from the patient's own cartilage, where we obtain the cartilage from within the lesion and from peripheral portions of the knee. This then acts as a source of chondrocytes, autologous chondrocytes, for the patient. The growth factors are obtained from PRP, obtained from the patient's peripheral blood, and then processed intraoperatively. And the matrix for fixation is again obtained from the PRP and platelet pool portion of the peripheral blood to obtain a fixation matrix using a thrombin. So we don't have a need to use any commercial thrombin glues. The whole procedure is autologous from the patient themselves. So this is a brief summary, because I know we're short on time. So we use a processing machine to create the blood, for peripheral blood, to create PRP. We use this device to create the thrombin glue from the patient's platelet poor plasma and PRP. At that time, we then harvest the cartilage from within the site of the defect and peripheral sites, collect it in this collector device, the graft net. And this very nicely then provides us with the autologous cartilage chips, morselized, ready to use. Dry arthroscopy or mini open approach is absolutely fine. We dry the area, we mix the chips with PRP to improve the flow predominantly within the delivery tube. And this is the delivery tube, so going in, all arthroscopic. And then this is seated on the defect itself to fill and contour the defect. So we can go up to quite large lesions with this. And then the residual, the autologous thrombin glue is injected to try to convert the fibrinogen within the PRP to fibrin and then stabilize this lesion by forming a clot. So that's a purely autologous procedure that we tend to use for the larger lesions. And that's what we're tending to use at the moment. So in summary, it's crucial, as I've previously said, to address coexisting factors, malalignment, ligament laxity, and meniscus deficiency when treating any cartilage problem. I think we cannot overemphasize that. The approach does need to be individualized, both for your geographical location, surgeon's ability or availability of techniques, the patient, and of course the lesion. We need to be aware of the limitations of each of our treatment options, and collaborative outcomes assessment, I think, is the way forward here to try to obtain more and more data, higher quality, to help guide us all really in this. It can be a quite difficult field of treatment. Okay, and with that, I'll stop there.
Thank you. I think you covered most of them. Hey, I want to know a few. Let's see if there are any questions in the chat box first. Nothing at the moment. But, these cartilage chips that you are using, single stage procedure. And where do you get the cartilage from? Is it from the motorized shaver that you are using?
Yeah, so we use the Arthrex Sabre shaver.
Yes, yes.
The 3 millimeter Sabre. So that very nicely creates the chips. And Arthrex did some work looking at different shaver types. So I think the Excalibur, they looked at the torpedo and the Sabre. And the Sabre created the most uniform chip size.
No, in fact, it came to me also, the same one. I used only one case so far, the same thing.
Yeah.
But you reckon that it's just checking the most surface cells out, isn't it? Yeah.
Yes.
Surface cartilage cells. Yeah.
Yeah. So because of the need to preserve the bone underneath, so the need really is to try and preserve the subchondral bone. So how best to fill larger defects by maintaining that bone, and how best to obtain autologous cartilage. Because until now, our main source was use of, for example, OATS.
Yes. And how long is
autologous? I'm sorry?
How many years outcome do you have right now for these kind of?
So Gian Salzman has the largest clinical series. He's the initiator of the study. So this was in 2019. He published his results of 27 patients. And we've been continuing the study now for about 1 year. And I think we have about 150 so far.
Okay.
Throughout the group. But this is a 2-year prospective outcome study. So.
And if it is very successful, it's a very cost-effective procedure also.
Yes, exactly. Yeah.
ACI, it's a very cost-effective procedure. And it's done in single stage. But it's showing a good outcome, then it is really promising.
Yeah. So we're going to have arthroscopy and MRI data as well with this study, as well as functional data. The main difficulty in my own experience with this has been getting the dry arthroscopy. It's very, very fiddly to get dry arthroscopy and also to treat patellar lesions because you're working anti-gravity and this does not work.
Correct. Yeah.
So I tend to do some of those mini open. It's a lot safer, reproducible, and I think it's better for the patient.
Patella, I also do mini open only.
Yeah.
And it's I think too much demanding, and you may not feel fully satisfied and do that.
Yeah.
So mini open is perfectly acceptable, no doubt about it.
Very much. I'm a big fan of this. Yeah.
There's a question in the chat box asking about cartilage chip harvested from non-weight bearing. No, we can be harvest from anywhere, isn't it?
We harvest from within the lesion, firstly, where there are always cartilage flaps that normally we would just shave and throw away. So that's from usually a weight-bearing portion where the defect is. And then we will harvest from the periphery, so the intercondylar notch, supratrochlear ridge. I don't think that load-bearing status matters so much. The key factor is it's autologous, and we're going to cover the area, so we need volume to cover the defect size.
So because we are not really going to the depth of it, so we can take it, ideally we can take it from anywhere.
Yes.
Not it's preferable, but you can take it from anywhere. There's no big difference in that.
Yeah, I think when you talk about sort of load bearing or not, it's very important to restore the congruity when repairing the lesion. And this is a big problem we have with mosaicplasty. We cannot restore that congruity of the condyle. Whereas with this lesion, it's a paste. It's like a putty. You can just mold it to the defect size and restore congruity.
Yeah. Any more questions from anyone? Arjun? Unmute yourself.
Very good talk, sir. Sir has covered everything. So, no questions.
Post COVID the மாதிரியே இருக்கு. தான் வந்துச்சான்னு தெரியல. பாசிட்டிவ்னா ஓபிக்கு வர முடியாது. வீட்டுல வேற டார்ச்சர் போடுவாங்க. அங்க போகாத, இங்க போகாத, அவன்கிட்ட பேசுறது.
I think somebody is not muted. So everybody hears some noise here. Yeah. So I think we are on time. It's 9 o'clock. Good. I like to finish on time. Very nice. So I think both Dr. Balasugumar and Dr. Rajesh covered very well about the evidence, and you shared your experience fantastically. It was pleasing and very nice to hear everything from you. And with this, we are coming to the conclusion of this program.
Sir, in the Indian population, what do you feel about this? Because a young age and the cost factor is there. So,
for India, what I thought is initially BMAC was very promising when it came in because it was at a lower price and we managed to do quite a lot. But I personally found out myself that some of the patients, actually 2 patients where I had to go in for arthroscopy, I only saw fibrocartilage. It was not very convincing then. So there are so many articles about good and bad things about BMAC. Next thing is OATS is actually a reasonable procedure for a smaller defect. It is possible. ACA is a bit larger game because of cost purpose in India. It has a 2-stage procedure. But recently the cost has come down. In India also the cost has come down. So that can be taught about, and counseling patient is very important because in our scenario, for them to accept for a 2-stage, 2 surgeries is you have to counsel them. Only the sporty population who are in trauma, in the sports, younger generation who really want to go back to sports, they are the only one who will like for it. The middle-aged group will not even think about it. So we have to think for other procedures only. Now they won't go for ACA at all. But this alternative, this chips, cartilage chips, which is a single-stage procedure, is really promising. If it has a good outcome, it will show a really promising, and it will also be cost-effective also. And this will be the summary for our Indian population. It has come into the market already. Arthrex has brought it. And I used one case last year. Before COVID, I used one case. After that, they have not come very much, and I have not had a chance to use that one very much. But it is available right now.
Well, hopefully I get to come to India soon. We do one together.
Yeah. And you favor that, cartilage chips?
Yeah, that's what we're using at the moment.
Yes,
mainly because for the bigger defects. Yeah.
Yeah.
And smaller, we use nanofracture and scaffold.
Okay. Fine. Fine. I think, thank you very much. We are coming to the conclusion of the session. I thank all the faculty and I thank OrthoTV channel, and also I thank Sun Pharma Group for organizing this program. Thank you one and all. We will see you again in a couple of weeks' time. Next week, we are not having the 3 series, but the week after will be there. Thank you. We'll see you again.
Thank you.
Thank you, Rick. Keep in touch.
Thanks very much. See you soon.
Yeah, thank you.